Okay.
So hi, I have the pleasure today to speak with Dr. Simon Luck. Simon is fantastic researcher and fantastic clinician with special interest in patellofemoral joint pain. And I'm really thrilled to speak with him about this. Hi, Simon.
Hi, morning, Marcus.
Simon works at Queen Mary University doing his research, and he also works practically in London with patients. And I think he combines both his research knowledge and also the practical knowledge perfectly. And that's why I find it quite good that he's my first interview partner. And I think that's also one reason why Globalsportscare has been started to actually translate scientific evidence a little bit more into a clinical practice. So as we want to get right in there, maybe Simon, tell us, what is patellofemoral joint pain?
Yeah, good question. And thanks for saying that I blend it perfectly, Marcus. I'm 100% confident that I don't blend it perfectly, but between clinical practice and research, but we do our best. Yeah, patellofemoral pain, really interesting sort of diagnosis, because predominantly we talk about that, and when we deliver courses, etc., one of the staple lines that we use is that patellofemoral pain is a diagnosis of exclusion. And what we do with that is that we aim to exclude any other intra-articular or concomitant injury in the knee, and in order to arrive at this diagnosis of patellofemoral pain. That said, it's an exclusion, it's a diagnosis of exclusion, but with some particular inclusion characteristics, that of insidious onset anterior knee pain that's aggravated by common provocative activities in the form of stairs, jumping, squatting, etc.
And we discussed a little bit also the term Contra Malaysia Patella. Some, especially the German-speaking part, use this quite a lot. How do you see this term compared to patellofemoral joint pain?
I think that that's sort of historically the term has been used synonymously with sort of patellofemoral pain, because it was always thought, you know, in the good old bad old days of biomedical model, where there was a tissue at fault, and therefore that would explain a diagnosis. Now, the challenge that we've got with chondromalacia, which is a descriptor used radiographically for certain characteristics that are seen within the patellofemoral joint, is or has been shown to be very poorly correlated with the degree of symptom severity that people are experiencing with this diagnosis of patellofemoral pain. So really, we kind of urge people to move away from making it a diagnosis of chondromalacia patella. We can talk about there being evidence of chondromalacia patella on your scan or X-ray, but those findings don't correlate tightly, so are not well associated with the symptoms that the patient may be experiencing.
So let's say you've got a patient who basically has those symptoms you described, has a scan of where it shows a little bit of chondromalacia. How do you explain to the patient what his or her problem actually is?
Well, and this I think we're going to cover in a little bit when we talk about these sort of top tips, really, because this is about how we identify what it is that we think is contributing to the individual's presentation. And that in itself opens up a little bit of an umbrella that we need to tackle. And I don't know whether we want to go into that in just a little bit, perhaps, Marcus, because we can't just simply go, oh, you've got chondromalacia, therefore you've got this presentation, job done, you know, and let's move on. There's so many more factors that need to be taken into consideration, in particular with a persistent pain complaint like chondromalacia, or with patellofemoral pain, I should say.
Yeah, well, if you want to go into this, I think we might well go to the next topic, that, you know, how, if you have a diagnosis of patellofemoral joint pain, how do you treat it?
Yeah, well, so we talked about this a little bit offline, and this was about, you know, what are the top 10 tips? If I was to speak to anybody, you know, what are the top 10 things that I think are really important for people to understand about this common pain complaint? And the first is that it's really quite heterogeneous. And what that means is, it's a scientific term, but that's meaning to say that quite a wide variety of people experience it. These could be military personnel, this could be runners, adolescents, and even some middle-aged people. And there's talk about the fact that patellofemoral pain may well be on a continuum towards patellofemoral osteoarthritis. So what this means is that quite a variety of people can experience patellofemoral pain. And so that's the first really important concept, I think, or thing for us to appreciate. It used to be thought of as perhaps just a adolescent-based problem, a growing pain. And whilst we do know that it is prevalent within an adolescent group, they're not the only people that may experience these types of symptoms. The second most important thing is that we've got to understand the breadth of knowledge and information and research that has been done around patellofemoral pain, because education, as we're starting to really understand, sort of forms quite the foundation of our management towards patellofemoral pain. So educating people as to what may be contributing to their symptoms, educating people as to what are the right approaches and why we're taking this given approach in order to manage their pain complaint or their presentation.
Yeah, and I actually do use a information leaflet Dr. Barton developed, and maybe I put this into the notes after this interview.
Yeah.
Is this still what you use as well?
Yeah, and I spend quite a bit of time after I've consulted with a patient. So I'll take their history, so I listen to their story, I'll examine them in clinic. I may use or have access to some imaging already, and then I spend quite a bit of time sort of almost debriefing after having gone through that process in order to talk them through what I think is going on, what I think is contributing to their symptoms, and therefore how we're going to go and manage it. So that comes on to my next point, really, my next top tip, really, which is about you've got to really understand the diagnosis in order to then start to get at and understand what are the drivers. So let's just stick with diagnosis for a minute. Diagnosis, as we just talked about before, is a diagnosis of exclusion. So it's critical for people to make sure that we haven't got meniscal pathology that may be giving them some anterior knee pain complaint, that we haven't got actually, we're dealing with something totally different in the form of patella tendinopathy or quadriceps tendinopathy, which we're going to manage quite differently to patellofemoral pain. So being very, very sure about that diagnosis and making sure that there aren't other things that we think may be contributing to their symptoms.
Good.
So that's number 3. Number 4 is this aspect of drivers, really. I've used the term drivers. For me, this is just a way of bringing together factors that we know are really important in this patient population. So one of them, or first one, really is about the way in which people move, about how they're built. So I term this, or this is termed, I should say, biomechanics. So how strong people are, what's their quality of movement, how flexible are they in areas, and looking at those components and thinking, okay, is this a relevant or important aspect of the way in which this individual is presenting to me in clinic? So biomechanics is one. Next top tip looks at structure. So we've got to consider structure. So we've touched on this. We talked about Contra Malaysia. That's a structural entity for me, a change in the cartilage that may be a component of the person's presentation. Or perhaps they've got a significantly anteverted hip, which is then driving a certain movement pattern, which means that they're increasing the relative load that is going down through the patellofemoral joint. Now, that doesn't mean that there's not an ability to improve them, and there isn't a need for surgery just because we're identifying a structural driver. It's just to say, okay, there are these components that we need to be aware of. So there's how you move, about how you're built or how you put together, or perhaps how the structure has changed over the course of time. And then volume, frequency, intensity, we use these terms quite commonly. It's like, how much are you doing? So is the fault or the driver based off of the fact that you're trying to do too much too soon? You've made a training error, that you're sort of trying to run a marathon and all you've previously ever done is a 5K, and the way in which you've got there is a little bit overnight. Is that where the fault is? And if that is the case, then obviously your management planning is very heavily biased or weighted towards informing and educating and upskilling and giving the patient tools in which they can manage their pain complaint and make sure that they get this staging or this progression just right. And then sitting above all of those is these variables that sit within a psychosocial domain. So an aspect of our pain processing that is so critical really for us to understand as clinicians if we're ever going to manage this individual optimally. Is it that they've got extremely high levels of anxiety, or that they're particularly low in mood, or they're very stressed out at the moment, they're sleeping really poorly, and yet then they've chucked a load of volume down, or that they've got a small structural deficit that may be contributing to their symptoms. Whilst they may have some evidence of Contra Malaysia, the fact that they've got a lot of these psychosocial challenges going on at the moment means that the small degree of signal that was coming from their knee initially is now amplified tenfold, and that's why they're presenting to you in clinic with significant pain and disability, really. So trying to capture an aspect of that psychosocial domain, psychosocial elements to the presentation is super important too, because once again, that's going to so heavily inform the way in which you're going to manage it. It may be that you decide that that's such a powerful driver that actually what you need is that you need another member of the multidisciplinary team in order to assist you in the management of that individual. And then that becomes something to discuss quite early and start to bring in a wider team in order to think that we're ever going to achieve a good outcome. So I'm down to point 7. Point 8, rehab. So it's now, I'm sort of coming down to rehab. Now you might have thought, well, that would have been number 1, right? The evidence is so strong that if we rehab people well, that we're going to get better or get these people better. But I don't believe it's that good. It's good, really good, but it's only good when we use it in the right context, when we're educating people appropriately, when we're really understanding what it is that is contributing to their symptoms. Because if they've got a biomechanical deficit, they've got some specific strength deficits that you think are contributing to their symptoms, then the rehab needs to be focused on developing strength. It's no good just doing a rehab program that's going to just do a little bit of yellow TheraBand type exercise, which is really low level, which might get them a little bit, but it's never going to get them all the way better. And so the evidence is really good for rehab. I use the term, rehab begins with the end in mind. I think it's so important that as clinicians we think about where is this individual wanting to get to. Are they going to just want to be climbing stairs and that's going to be a successful outcome, or are these individuals who want to be in the gym squatting heavy, that's part of their goal, or is it that they want to be running half marathons or marathons, or what is their goal? So rehab begins with the end in mind. Number 9 is hip and quad. So I wrote a systematic review with some colleagues now back in 2015, and that systematic review looked at hip or proximal rehab in people with patellofemoral pain. The conclusions were if we rehab around the hip and the knee, we're more likely to get a successful outcome. So really make sure that we're rehabbing these individuals quite hard and pushing their hip and quadriceps strength, if that is, again, identified as a deficit.
Sorry to interrupt. Do you also think that there's the degree of progression here quite important, depending on what you achieve?
Absolutely. Like, I don't think rehab really is rehab without progression, if I'm honest. You've got to be progressive, but you see, where your progressions kind of stop is going to be reflective of where that individual wants to get to. So there may be some that really need to go through the neuromuscular strength, endurance strength, and into some power phases in order that their rehab is fully complete and that they've progressed through each of those particular domains. It may be that some don't need to be progressed to that level and that they could exist just within a strength endurance domain, but there is a progression that matches their goal. And actually, go on.
And do you use still measurements, strength measurements or functional measurements, single leg squatting, or what tools do you sometimes use?
Yeah, we're trying to bring more and more measurement into clinic for not only to justify and validate a little bit of what we're doing or the approach that we're doing, but to really give that kind of feedback to the patient also. So we use handheld dynamometry as routine here at Pure Sports Medicine. We've just recently acquired some force plates on loan from Valve for a short period of time, and we're experimenting really as to how we integrate those or measurements that we can obtain from those into our clinical practice too. So yeah, lots of measurement, and then obviously sort of your more sort of traditional, I suppose, measurements in the form of subjective history and VAS scores, so pain level scores and functional scores as well. So we use the PSFS really routinely here as well. So that's the patient-specific functional scale. I talked about goals. You know, goals are sort of embedded within that. So people may come in and say, you know, I'm having difficulty being able to walk stairs. I'm having difficulty being able to sit to stand. I'm having difficulty being able to run 5K. Well, those become our patient-specific functional scales, and we'll ask people to score that between 1 and 10. So 10 is that they're able to do it without any limitation, and 1 is that they're completely unable to do it because of their knee pain. So then we'll match out, or we'll re-ask those questions as we go through treatment to see if we're making changes. Okay. Final point, really, and I think that this segues really nicely from what we were just discussing. It's about build capacity, and that, I think, for me is sort of integral to all of what we do with regards to rehab. It's about building capacity, and I use this term quite a lot. I want to make sure that you've got enough capacity in your knee markers such that, you know, it doesn't matter what you do on a day-to-day level, you know, that you've got enough capacity that sits up here. That means that day-to-day never really touches into that or looks to exceed it. And so that's a massive part of the way in which I'd communicate what we're trying to do with our rehab planning or any intervention really is build capacity. So that could be within a psychosocial domain. You know, we're trying to build your psychological robustness, so there's enough capacity in there that it doesn't matter what stressors come your way, you know, that you're really solid on that. So that then that's not going to ever tip into a point where it starts to flare up any other of your musculoskeletal complaints or knee pain in particular.
And with the last point, do you use other practitioners then if you speak about psychological robustness, or will you, as a physiotherapist, need some additional education, or how would this work?
Yeah, I do genuinely feel that this sits in a bit of a grey zone, like a lot of these things, really. That there's a certain amount of skill that I think that I feel like I've acquired over the years, working alongside some psychologist colleagues, but also working in more persistent pain groups that are psychology led and so on. But and gaining some education from people who do a lot of work around the pain sciences. You know, they sort of touch on a lot of those domains. But I do think that there are people that clearly sit outside of what I feel that I'm capable to affect with the interventions that I can offer. And at that time, then I would look to bring in a psychologist or bring in another member of the team. But I do think that there's a lot of psychological benefit in what we do as physiotherapists. You know, we help to get people moving. We promote activity, and we know, and so much of what's being talked about within the evidence more widely at the moment, that those types of active interventions can have a very positive impact on people's mental health, as an example. So I'm not by any means saying that we can cover all with that. What I'm saying is that there's a lot of what we just do instinctively or forms an integral part of what is physiotherapy that has a positive impact upon those domains. But there will be some individuals, some patients who present for whom that's such a big component of their presentation that actually that sits beyond what you're likely to do. But I don't then think, oh, well, you just send them off and then you don't do any of what you're looking to do in terms of intervention. You do that alongside. You optimize function alongside it.
Well, I think that brings me to the next point. And, you know, we've had those patients who have had all those points you've had, and they still have pain. And is there anything else you consider, let's say, sending somebody off to a podiatrist for, you know, a proper biomechanical analysis, or the other thing is other interventions like injections?
Yeah, definitely, with all of the above. So podiatrists, for sure, use our podiatry colleagues quite heavily here. We're very fortunate to have them in site or on site here. And there is a bit of a challenge to sort of say, okay, how or in whom is the foot or the distal biomechanics contributing to their presentation. And if you're uncertain, it may be that you send them off in order for that gait analysis to be done and for the podiatrist to inform that decision making. We use some tools, or I use some tools in order to predict that. Sometimes I might tape someone's foot if I'm looking at their move, and I see that the foot is contributing or looks to be a component of the way in which they're moving into that more sort of dynamic valgus-y type position, and having listened to their story and taken into consideration the much wider sort of number of factors that we know contribute to people with patellofemoral pain, and I think that that's an important component to it, then I'll look to intervene at that level. Injections, definitely, you know, I think that there's a role for it. The evidence, as we've discussed at length, Marcus, you know, the evidence for it is still emerging. But in some individuals, I think that it providing an opportunity where there is less discomfort within the knee in order to improve perhaps movement patterns or muscle capabilities or flexibilities, etc., then I think that they're can be an extremely useful adjunct.
Yeah, and thinking about it with the biopsychosocial model, if somebody is pain-free for a while and has had it for years, then they actually realize, oh, you know, I can be again pain-free, even if it's for some time to help you aid the rehabilitation.
Yeah, and I often sort of I often arrive at a conclusion or a discussion point where I'm saying to people, look, in an acute setting, perhaps there's a very tight and intimate link between the symptoms that you're experiencing and what's going on at a tissue level. But as time passes, actually those two things become separate entities that need to be managed a bit separately, but whilst also being managed together. So, you know, an injection may really quite heavily target the pain component to it, whilst then we optimize some of the sort of the mechanics and the tissue health around that, and hopefully that those two things come together. So for certain situations, I think that that's entirely relevant.
Well, that's great. I think we covered quite a lot, and I think you also build a web page, I think, for some information. Tell us a little bit about your web page.
Yeah, we're doing quite a lot of work on that at the moment. It's teampfp.com. So teampfp.com. This is with my colleague, Dr. Bradley Neal. He and I do a fair bit of teaching together, but we really want to provide a platform to grow the knowledge and information for both clinicians and for patients as well. So we're doing quite a bit of work on that website currently. So it's sort of it's there, and there's some information on there, but there's much more coming in the next few months, we hope. So yeah, by all means, jump on there and have a little look around and see if there's some stuff there that's of interest. There's a few educational blog type posts that hopefully you might find interesting and sort of talk a little bit more about what I've just been discussing here today. Well,
Simon, like always, I only can thank you for your time, and I will pop all the links onto the blurb of this video, and any future developments, I'm sure we will discuss those here.
Yeah, thanks, Mark. Cheers.